Assalamu alaikum. Today we are going to study about the anatomy of the temporomandibular joint. So temporomandibular joint, these are the joints between the mobile mandible and the temporal bone. So this one is the mandible and this is the temporal bone. So it is the joint between both these two. Each joint contains two joint spaces which are separated by fibrocartilaginous articular disc. So we can see the two joint spaces here. This is the upper joint space and this is the lower joint space, and in between we have a fibrocartilaginous articular disc. So TMJ is a compound joint and it is considered as gangliomodiarthroidal joint because it has the capability of both hinge type and sliding movement. Okay, we use the term compound because it is composed of three bones, namely we have the mandibular condyle. So we'll see this is the mandible, and if I remove the temporal bone, we can see the structure here. This one is the condyle. So this is the mandibular condyle, and now if we remove the mandible, we can see the temporal bone more clearly. So this is the temporal bone. So the squamous part of temporal bone is involved, and also we have a non-ossified articular disc. So TMJ is an articulation between the condyle of the mandible and the squamous portion of the temporal bone. Now we'll study about the components of the TMJ. So first one is the glenoid fossa, and then we'll go on to the articular eminence or protuberance. So if I remove the mandible, here you can see a depression sort of thing. This one, this is the glenoid fossa. So it is a well-defined hollow area on the inferior portion of the squamous temporal bone. So this is our temporal bone and this is the inferior portion of the temporal bone. So here you will find a well-defined hollow area, and if you tilt the skull this way, you will see that anteriorly it is limited by this structure here. This is the articular eminence. So this is our fossa and this is the articular eminence. So convex articular eminence forms the anterior limit of the joint. The glenoid fossa is covered by a thin layer of fibrocartilage. So it is covered by a thin layer of fibrocartilage. Now let's move on to the mandibular condyle. So let's see, this is our mandible. Now we'll remove the temporal bone. So this is the mandibular condyle. So condyle is elliptically shaped with its long axis oriented mediolaterally. The dimension of the condyle is roughly 20 mm in the mediolateral direction. So this is the mediolateral direction. This is the medial side, this is the lateral side, and the dimension from here to here, it is 20 mm. And in the anterior posterior direction, it is 8 to 10 mm. So from here to here, from here to here, it is 8 to 10 mm. And like the glenoid fossa, here also we have the surface covered by fibrocartilage. So here also we have fibrocartilage covering. So that is why the TMJ is called the modified type of hinge joint, because in hinge joint we have hyaline cartilage, but here all the surfaces, the glenoid fossa and the mandibular condyle, both these are covered by fibrocartilage instead of hyaline cartilage. So it is a modified type of hinge joint. Okay, so this is a diagrammatic representation of the TMJ. So we'll start with the structures we find here. So this is the condyle, and this is the mandibular fossa, and in between these two we have this purple thing here, which is the articular disc. So this is the articular disc, and we'll see the shape of this disc in a while, but before that let me finish all the structures. So this right here is the articular tubercle or articular eminence. articular tubercle, and we can see that this purple thing, it is dividing the cavity into two spaces. So we have this space on the top and this space in the bottom. So this green one, this is the upper joint cavity or superior articular cavity, upper joint cavity, and this one, it is the lower joint cavity. So the articular disc is dividing the cavity into two spaces. Then right here, this thing, this is the post-glenoid tubercle, post-glenoid tubercle. My handwriting is really bad. And this is the styloid process. This is the styloid process. This is the external acoustic meatus. External acoustic meatus. This is not a universally accepted short form. This is Hina's short form. Okay. And yeah, this is the lateral pterygoid muscle. So this is our muscle here, and I'm coloring the muscles into two because of certain reason, and I'll tell you why. So both these are the lateral pterygoid, but this is the superior head of the lateral pterygoid, superior head, and this is the inferior head. Okay. What else is left? Yeah, one important thing is left. This light blue thing here, this is the joint capsule. This is the joint capsule. Alright, so let's talk about this joint capsule. So let me try to give you a clearer view of joint capsule if I could, because I'm not a good artist at all. Okay, so this is it, and where is the condyle, man? So here will be our condyle. This is gonna be our mandible. This is our mandible, and this is the articular eminence, and here we have the joint capsule. So this is our joint capsule somewhere here, and here we have external acoustic meatus and the other structures behind. Okay, so the joint capsule is a fibrous membrane that surrounds the joint, and it incorporates the articular eminence as well. So you can see it is kind of incorporating or including the articular eminence as well, and it attaches to the articular eminence, then it attaches to the articular disc, which is present somewhere here. Okay, and the neck of the mandibular condyle. So all these structure it is enclosing. Superiorly it is attached to the temporal bone, okay, and inferiorly it is attached to the neck of the mandible, or say neck of the condyle to be precise. Okay, the inner surface of this capsule, it is covered by synovial membrane that aids in the secretion of synovial fluid. So it has a synovial membrane and that secretes synovial fluid, and this capsule, it confines the synovial fluid to the articulating surfaces. So for example, if this is the capsule and inside we have all the structures, blah blah blah, so this capsule, it will confine the fluid. So this is the fluid and it is secreted by the synovial membrane, and this fluid will be confined within the articulating surfaces. So it aids in lubrication and all. Now let's come to the articular disc. So let me do it in purple. So the articular disc is somewhat like this. It is a biconcave oval structure. This is one concave surface and this is the other concave surface. So it is divided into three zones. This in the middle, this is the intermediate zone. Okay, and this one is the anterior zone and this is the posterior zone. So as you can see, the anterior and the posterior zone, they both are thick, and the intermediate zone, this is thin. So these thick posterior and anterior band, they act as wedges, giving the disc a self-seating capacity. Because of the contour of the disc, the thick bands help preventing the displacement of the disc during translation. And in the intermediate zone, we don't have blood vessels. So it is avascular, vascular, and we don't have nerves also. Nerves are also not present. So this area, it is a pressure bearing area. So this is a pressure bearing area. So let us see the disc here. So this is a very horrible diagram. So let us move to this diagram right here. So in this you can see, this is the posterior thicker zone and this is the anterior thicker zone, and between them we are having thin intermediate zone. Posteriorly, the meniscus is contiguous with the posterior attachment tissues, which are called the bilaminar zone. So this bilaminar zone, which is present posteriorly, it is vascular. This in the middle, intermediate zone, it was avascular, but the posterior one, it is vascular and it is also innervated. So that is why in some cases when there is disc displacement, when disc is displaced, this vascular structure, it comes in between, it comes here, okay, in between the condyle and the articular eminence, and since it is vascular and innervated, so it cannot bear pressure, right? So the patient will have a lot of pain in that case. As already told, the disc divides the joint space into two compartments. We have the superior joint space and the inferior joint space. So superior joint space is bounded above by the articular fossa and the articular eminence, and the inferior joint surface, it is bounded below by the condyle. And both joint spaces have small capacities, means the passive volume of the upper joint space is about 1.2 ml. So the passive capacity is 1.2 ml of the upper joint space, and the passive volume of the lower joint space is around 0.9 ml. So this is our condyle and this is the inferior surface of the disc. So the condyle joins the inferior surface of the disc to form the lower joint, which is called the disc condyle complex, where only hinge or rotary movement occur. So in this lower space, only hinge or rotary movement will occur. And in the upper one, translation or sliding movement will occur. So whenever the mandible is functioning, this thin intermediate zone is always present in between the condyle and the fossa. And this maintains the stability within the TMJ. So during disc displacement, this intermediate zone, it is shifted from here and the posterior one comes forward and causes pain and associated symptoms. Now let's talk about the synovial fluid in a little more detail. So the main functions of synovial fluid is to nourish the avascular articulating cartilage and provide lubrication between the articular surfaces during function. So it is a clear, straw-colored, thixotropic fluid, which is composed of mucin and some albumin, fat, epithelium, leukocytes, and it also contains lubricin, which is secreted by the synovial cells, and it is mainly responsible for so-called boundary layer lubrication, which reduces the friction between the opposing surfaces of the cartilage. Okay, so what happens is when the mandible moves, the synovial fluid will be squeezed out mechanically and it will maintain a layer of fluid on the cartilage, and this is called the weeping lubrication.